Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
McDonald Pinkett referred to last week. I talked about one of the biggest problems we have in the world, which is high blood pressure and cardiovascular disease itself. And talks about the systolic and diastolic blood pressure, which many of you already know about, but also talks about the problem that we recognize that only 1 in 4 adults with high blood pressure has the condition under control. So three out of 4 people who have high blood pressure don't control it, and 56% of Black adults have high blood pressure, which is an alarming number, particularly if 3 out of 4 of them it's not controlled. Then some people will be alarmed by the fact that blood pressure is best measured at home by you. And this is important to keep in mind, that sometimes you go to the doctor's office, it may not be taken, and you may have high numbers or that do not reflect what your blood pressure normally is. So you should be taking your blood pressure at home and recording it and taking it to your doctor, so he can look at that and compare it to what you get at his office. And then you heard this forever, but we repeat it again: that exercise and meditation for these 150 minutes per week will help maintain a normal blood pressure. And of course, fruits, vegetables, plant-based proteins, and water will help prevent chronic diseases. None of this is new to you, just rehashing and reminding. The issue of alcohol use is an interesting one, because for those who are alcoholics, 1 drink is enough to start the problem. Whereas for those who aren't alcoholics, 1 drink is allegedly good for the stomach's sake. So, but those people who are concerned about the vulnerable populations would say that no drink is good. But anyway, most people, most articles say that 1 to 2 drinks a day may be healthy for most people. And then taking your blood pressure medications as directed, and then if you get side effects, remember, I think the only medication I know that doesn't have side effects is water, and sometimes the air we breathe, sometimes. But other than that, and so the issue about side effects is that when you have side effects, you have to get in touch with your doctor and stop the medication and find out what medication can replace it. Because now we have so many antihypertensives that if they have side effects, you can take a medication that doesn't give you the side effect that you have a problem with. In terms of how do you know you have a side effect? If you have any symptom that you didn't have before you took the medication, that's a side effect. Now, if you want to, you can read all of the side effects that occur from your medication, but there's so many that you may be frightened. But any symptom you have that you didn't have before you took the medication is presumptively a side effect. Then, of course, reducing the sodium and salt in your diet is important. I think that you should keep it at around 3 grams a day or so. But why we have increased sensitivity to salt, I'm not sure we totally understand, but it is something that we know we have. Then be mindful of your cholesterol level. uh, they often go together. And if you got high blood pressure, you should check to make sure that your cholesterol level is normal. Normally, you want to have the good cholesterol and the bad cholesterol, and you don't want it to be too much over 100. But this is something that you should get probably once a year. Yeah. And then finally, 7 to 9 hours of sleep are recommended. They've done studies that show that 6 hours is not good enough to keep your brain in good function. But 7 to 9 is the ideal. So those are some of the things that we've discussed ad nauseum throughout our meetings. But any comments or questions, disagreements?
As far as the sleep is concerned, it doesn't have to be continuous.
No.
Okay. Good. Yeah.
Any other comments or questions? If not, this is an article that is interesting because the maternal mortality rates among Black women is undesirable. Let's put it that way. Although there have been some recent articles that suggest that this is a data anomaly, the fact is that the data does indicate that the mortality rates among Black women is unbelievably high. That's the best I can say about it. And we have to be very aware of this, and because of that, it means that you need to go to your doctor and be taken care of from the time you find out you're pregnant until the time you deliver. And there are many problems that occur with pregnancy that can be diagnosed and treated before the actual delivery. And then, of course, the fact that you'd love to have zero maternal mortality, but we have one of the highest maternal mortalities in the world. And why does the richest country in the world have the highest maternal mortality rate in the world, particularly among Black people? And so this is certainly a concern. And this article is suggesting that going to the doctor early on in the pregnancy might contribute to lowering this incredibly high maternal mortality rate. And we know that at the bottom of it, that you might say that having more Black doctors would help a lot, and it would. But in the absence of doctors, having more Black doctors, then going to the doctor earlier on in your pregnancy would help considerably. Any comments about this article that addresses one of the most serious problems in the United States?
Dr. Callender, do you think it has anything to do with people waiting longer to have at an older age to start having children?
I think it has to do with people when they're pregnant not getting the care that they need, and especially older women would need to start having their care earlier, so that once you find out you're pregnant, I think it's important for them to be treated by somebody who can make sure they diagnose early any complications that occur in the child or the mother. And yes, having older mothers will contribute to the problem of mortality, as you had suggested.
That kind of stuff.
So, Dr. Callender, I was just wondering if you take out the totals for the Black women just the white mortality rate, the white women's mortality rate, is that still higher than the international rate?
Yes, but it's not. Yeah, it's high. It's still higher. Yeah, but it's
So
just that the black mortality is 3 times higher than the white.
Wow.
that's really something.
Yeah, it's so early. I think earlier care will contribute to it. My mother died when I was born, and of course, in those days they didn't have antibiotics. So, uh, but certainly, of course, she they wouldn't even let her in the hospital. Then those days, the blacks didn't go to the hospital. So, but anyway, those issues that are better now. We have better care if we, but we don't take advantage of it. Lucia, you have any other thoughts? Dr. Perez, you have any other thoughts? Not any other comments? So that is one of the data items that we need to keep aware of. And when our children and grandchildren get pregnant, make sure they go to their doctors and get checked up. One of the biggest problems is preeclampsia and in addition to diabetes and kidney failure. This is something that we're all aware of, but just to remind you that the COVID vaccine booster shot is now available for those of us who are over 65. And it is recommended that the booster shot be taken 4 to 6 months after the last COVID shot that you got. Have most of you gotten the additional booster shot? I haven't gotten mine yet.
Not
I
yet.
was trying to get
Not
mine
yet.
Yeah.
tomorrow.
Dr. Callender, how
Yes.
do we track this? It's not like the flu shot, and of course we get that every year around uh, early fall. Um, I thought I know I have had all of my shots as far as COVID, as far as this one. So will the COVID booster be due every year? What, in
No,
March or?
this one is due 6 months after 4 to 6 months after you had your last uh, COVID shot. Whether this is going to be necessary every 4 to 6 months, I'm not sure. But
Mhm.
as of now, the answer would be yes. So that uh, 4 to 6 months after you had your last COVID shot, you need to get another COVID shot.
Oh, so it's more regular than once a year that we're getting
That's
this.
correct.
Oh,
That's correct.
okay.
It seems like it's going to be every 6 months.
Wow.
So far, we don't know. We'll have to see. Any other questions about the COVID booster?
You did say it's available now, correct?
Yeah, it is now. Yeah.
Yeah. We got our last ones in October, so I guess we
Mhm.
need to go.
So it's, as long as you had it longer than 4 months ago, so October would be okay. November, December, January, February, March would be 5 months.
Okay.
I think as long as you get it within 6 months, you're okay. This is an interesting article that suggests that if you get multi-dose shots like for COVID, and you get that if you put the second shot in the other arm, that increases the efficacy of the vaccine. This is an interesting finding, That is a new finding. So that if they got it in one arm last time, putting in the other arm seems to activate new lymph nodes and
Okay. I have to remember.
increase the efficacy
Right, to my
of
left.
the
It was
vaccine.
all right.
Any comments or questions about this?
So you're saying if we took a shot in our left arm for COVID in October, then we should go to the right arm?
That's what they're suggesting, yes.
Okay. It doesn't have anything to do if you're taking the flu shot and the COVID at the same time?
No.
Okay.
I guess, Dr. Callender, you're saying also with this article that we need to keep a better account of when we're vaccinated and where we're vaccinated, so that we incorporate that in the information that we carry on ourselves.
Yeah, very good idea. Very good. Especially now that they're putting it back on us. So you're going to be the one that has to document when and where you got your shot and which arm you got it in. Yeah. An interesting article on COVID vaccines and the side effects. Just as we said, with every medication, there's side effects. Well, even with vaccines, there's side effects. And there's an interesting article, very complex, that talks about the number of side effects. Often, sometimes, maybe 1 in 100,000, but nonetheless, there are side effects. And one of the side effects is blood clots with certain vaccines, and then there's other side effects which you've heard about. Heart inflammation is one of them, and then of course there are others such as, in addition to the myocarditis and pericarditis, there's the Guillain-Barré syndrome, which occurs in about 1 in 100,000 patients, and and then that doesn't really even talk about the fever, chills, and the fatigue and other minor side effects that occur. But so there are side effects that occur as a consequence of the vaccines. It's just that they're very uncommon and can be associated with some vaccines rather than others. The Guillain-Barré is something that is uncommon, but yet is noticed. And the only one that we really don't really see much about is the one that they talk about, which is autism. Anaphylaxis is very rare as well, but 5 per million doses, which is pretty unusual, and even death. And it does occur after COVID vaccination. So it is true that there are many benefits of the vaccine, but there are also side effects. So we can't be blind to that, but we have to recognize that as a consequence of the vaccine, you have 20 million fewer deaths than you would have had otherwise. So you have to take into consideration the risk-benefit ratio of the benefit of the vaccine versus the side effects that occur. And as a consequence, you have a so-called vaccine hesitancy, where 18% people don't get vaccinated because of the side effects. So there's no question, yes, there are side effects, but when you compare them to the 20 million lives saved, you think that for many people, the cost risk benefit ratio is great. But this is a topic for discussion. Any comments, additional thoughts about that?
Even though African Americans, Black people have been part of the research, it's really important that side effects and going forward, we follow and report those side effects. Because our representation in the development of the vaccine was around 10 to 12%.
Good point. Okay. Any other comments before we move on? Because this is a pretty timely and potent issue. Okay. Hearing none. There have been all kinds of efforts to increase the flu shot, but still close to 20% of people are not getting flu shots. Actually, percentages that are not getting it may be higher than that, but why? The question is why. And I guess if you have any side effects, people think, well, I'm not going to get a flu shot. But for people of over 65, and it's riskier to get the flu than it is to get the vaccine. Still have a lot of people who don't get any vaccines regardless, because they have heard about people who've had the side effects of the vaccine. But it is, as you age, it's riskier to do without it.
And I think another point that I believe is important is access to primary health care, because those discussions about risk and benefit ratio, because there's a decrease in access to primary health care and physicians and other healthcare professionals, those discussions are not happening at the rate that we would want them to. There was a lot of access when at the height of the pandemic, and many of those disparities in access to care were uncovered. Yet now that the pandemic has waned, we are not, many of those access points are no longer available. And I think that that's a tragedy.
Any additional comment?
I have a thought, Dr. Callender and Dr. Perez. If the flu were killing people like COVID, more people would get the flu shot. That's what I believe. And since, maybe not that many people actually die from the flu, that's why the rates are so low.
And I think we can look at it that when marginalized people had the potential to infect other people, then access was made available.
Well, it's interesting that with so much misinformation out there that people still are not being vaccinated. But it's just something that we have to try to deal with by, as you mentioned, having more people actually communicate with their primary care doctors about the cost-benefit ratio. And we're hopeful that we don't need more people to die from the flu to cause us to get vaccinated, but that may well be the case, as you suggest, Mr. Buchanan.
I just asked my husband why he didn't get the flu shot. Years and years, he would not get the flu shot. And he just told me that when he was somewhere he was working, they had the gun and they shot it. You remember when they used to administer the flu shot with the gun? And he said after he got that one time, he just wasn't getting it anymore. But I finally convinced him to start getting it again. So after COVID, I think he went and got all the shots that were available.
Yeah. Which goes along with John Buchanan's point, right?
Dr.
Now
Callender,
that we got, yeah, go ahead.
So the flu shots and vaccinations were up prior to COVID. I mean, are the percentages higher prior to COVID?
I don't know the answer to that question. I just know that they said that the rate has dropped. To the extent to which it has dropped, I'm not sure.
Okay. I was just wondering how many people were actually getting the flu shot and were comfortable getting it prior to COVID. And then after COVID, maybe that, scared people. I don't know. But I was just wondering whether or not people were more apt to get the shots prior to COVID.
That's a very good question. I don't know the answer though.
Okay.
Now that measles is becoming active again, we have to make sure that our kids get the vaccinations before they go to school, because there are populations, there are states that are now having measles that they never had measles before, and there are more migration immigrants that come over who have not been vaccinated, and they may be the source of some of the measles. Some of the sources, people who just have not been vaccinated, but some of them have been immigrants who were not vaccinated.
And I think that's the point of herd immunity.
Well, yeah, of course, the point of herd immunity is kind of mitigated when you have a large immigrant population that has not been vaccinated. And the importance of herd immunity is that it protects against those people who are not vaccinated, if you have a large enough percentage that are vaccinated. And the concern is the lagging vaccination rates may mitigate against our herd immunity that has been protecting us all along.
I have a question, Dr. Callender. Once you get vaccinated like we did when we were kids, are we protected for life against measles?
Yeah, for the most part, yes. The answer would be yes. But those who have not been vaccinated, they're at risk. They rehashed the herd immunity concept that if you have more than 90% of the population immunized, then that would cover most of the population.
And correct me if I'm wrong, I thought the measles vaccination was a requirement to go into public schools at all.
It is. It is.
Okay.
It is, unless you have a medical reason for not being able to be vaccinated. But you're right. And you remember that in Florida, the medical director in Florida allowed people to get into school even if they weren't vaccinated, which is not a good medical practice. It talks about the other countries, including 26 in Africa, Europe, and Middle East. So measles is a disease that kills, and so the fact that one of the things that I found out when I went to Africa is that common diseases were killing people because they had not had vaccinations, including tetanus, which was the commonest cause of death when I went to Africa back when. And so that sometimes we take for granted the fact that we've been vaccinated, and as you mentioned, in order to get into school, for the most part, you need to be vaccinated. But there still are people who have medical reasons why they're not vaccinated. Any other questions about the measles? If not, this is an article that talks about blueberries and strawberries being very good, but the pesticides that are used have forced some people to say that they are not safe. And they talk about the clean 15 you see here: sweet peas, asparagus, honeydew melons, cabbage, watermelons, mushrooms, mangoes, blue potatoes, and carrots. But pointing out that while cherries and blueberries are good for you, the pesticides that they use make them relatively unsafe. EWG is a group that is very tries to be very protective to the United States, and the EWG has it's kind of the watchdog. Then there's a concern that pesticide levels are within the legal limits, but that's something that EWG doesn't agree with. And I think Darryl has pointed out that a lot of the pesticide levels that we have are banned in Europe because of harmful effects on human health. Any other comments about this article? Comments about EWG, which is an organization that is keeping in front of everyone's minds those practices and pesticides that are dangerous to us.
Yeah. A couple of obvious things with organic produce is that they're a little more expensive than conventional, and they will mildew faster. They will grow mold faster than the non-conventional, because like where the screen is right now, with the conventional they apply fungicides, and so they have longer shelf life. But you get what you pay for. You save a little money, you get longer shelf life, but you get food that's bad for you when you eat conventional food.
Any other comments? If not, and this talks about ways to reduce pesticide and emphasize no washing method is 100% effective.
Yes, it's always a good idea to scrub your vegetables and fruits because even if they don't have pesticides and fungicides, they're on the grocery shelves, and they're subject to people's handling with their hands, sneezing, breathing on them, and so on. So it's always a good idea to scrub and wash your fruits, your produce.
It's interesting, something that most of our farm bred people automatically do, just as Darryl had mentioned. That's another reason why many people don't eat out at all, because of the same reasons he mentioned. This is an interesting article, although not sure about whether or not it's been tested or not. In other words, they found this bacteria in 50% of colon cancers that protected the cancer cells from being destroyed by the human immune factors. What they didn't identify, though, is how treating these bacteria resulted in improvements in the cancer survival rates. But be that as it may, it has been found that just as we know that there are autoantibodies that protect cancer in the body from being destroyed, when our own immune system would destroy them, our autoantibodies keep them from destroying them. Similarly, there's some bacteria they've identified in the colon that prevent our immune system from killing the cancers. And so the theory is that if you kill these bacteria, that you would make more people able to survive their cancers. But they haven't done the next study that would prove the point. But this is a new finding that 50% of cancer have these bacteria that are preventing our immune system from destroying the cancer cells.
John Tatum has his hand up, Doc.
Go ahead,
Yeah.
John.
Yeah, good morning, everyone. Dr. Callender, I was wondering whether, speaking of fruits and vegetables, whether the skin of the vegetables and fruits play a role in the bacteria, because, of course, there's some fruits that we eat with the skin on it, and some fruits we eat with the skin off. One example, bananas. We eat bananas without the skin. We eat oranges without the skin, but apples we eat with the skin on it, grapes, blueberries, and strawberries and other fruits we eat with the skin on it. So my question is, does the skin of the fruit make a difference?
I don't know the answer to that question. Darryl, do you have any ideas?
Yeah, the thicker the skin, the less likely that the pesticides and the fungicides are going to be able to penetrate to the fruit. Like, say, for instance, bananas, generally a thicker skin. So conventional bananas will have pesticides and fungicides applied, but there'll be less pesticide content into the fruit into the meat of the fruit in a banana than, say, compared to a grape or an apple. So you're more likely with thinner skinned fruit to get more of the pesticides into the meat of the fruit. But still, if you're given a choice between organic banana and conventional banana, you're not getting all the pesticide into the meat of the banana with conventional, but you're better off getting none of the pesticide with organic. That's still a little bit of a crapshoot, because to be strictly organic, then that farming system can't have mixed conventional and organic, or sometimes if it gets water runoff from a conventional farm upstream, and then you get some downstream runoff to your water supply in an organic farm. The only safe way is to move out of America.
Okay. Any other comments or questions before we go to the next one? Okay.
And I asked the question, would you say that the amount of pesticide is based upon the lobbying impact that the industry might have?
You
had a
can go to
question.
the next article while you answer the question. You go to the next article.
I had a question about this one though, Doc. I was
Right.
just wondering if there's bacteria in your mouth.
Yeah,
Okay,
of course.
how could it get through your digestive tract without getting killed?
And they do it all the time, every day. Yeah, and that's why your GI tract is loaded with bacteria. That's why you talk about the good bacteria versus the bad bacteria. They get through the acid in the stomach very easily.
Okay. That was my question. I was figuring that acid is strong enough to kill some bacteria at least.
It probably is, but we still have copious bacteria in the small and large intestine.
And come back the next day to finish the job.
Okay. Let's go to the next one. You have people who have chronic coughs, and particularly people who smoke cigarettes or people who've had chronic lung disease. And many question why? Asthma, of course, the GERDs and other comorbidities cause a chronic cough. And this is an article that talks about the many disease entities that are associated with chronic cough, and they even have hypertension, although that's hard to view because hypertension is a silent killer. But of course, the others, asthma, GERDs, and allergic rhinitis, are associated with chronic cough. And when you have overweight, obesity, that contributes equally as well. And so this article is talking about those comorbidities that are associated with chronic cough. Asthma is well known, morbid obese patients as well. And of course, no question about the cigarette smokers who often get chronic lung disease. So I guess this probably is not considered as much in people who don't cough, but in people who have chronic coughs, this is an issue. And especially as it relates to females, African Americans, and cigarette smokers. Any of you fit into these categories?
One of my cousins, Dr. Callender, has a chronic cough, and she's not a smoker and not a former smoker or anything like that. She just has a chronic cough.
And that rhinitis and the postnasal drip is something that can lead to bronchitis, which can give you the chronic cough.
Okay. You answered my question before I asked it. By the way, Dr. Callender, we have a guest today. Her name is Pearl Lipscomb.
Welcome, Pearl.
Thank you. I'm just listening because
Good.
I am getting some information, and so far it's been very interesting.
Well, if you have any questions, don't hesitate to ask.
I certainly will.
Now, this is a disturbing paper in the sense that we're so well aware of hypertension and so we're well aware of the association of hypertension and cardiovascular death. But yet, with all of our awareness, as we mentioned earlier, 3 out of 4 patients with hypertension is not controlled. And as a consequence, the death rate has not really changed much, which is disturbing, which means that all of our efforts seem to have been in vain. And so therefore, the reason for us to talk more and more about the importance of people with high blood pressure taking their hypertension medication and controlling their blood pressure. Because if 3 out of 4 patients with high blood pressure are not controlled, then what's the point? The real goal is to get 3 out of 4 patients with high blood pressure to be controlled. And this then would result in a decrease in the death rate. And so this is why there's so much talk about treating high blood pressure and whether you should define high blood pressure as greater than 130 or greater than 140, greater than 90 or greater than 80. And the bottom line, though, is with all of this talk, the result of change in CV cardiovascular mortality is really relatively unchanged, which means that we need to do a better job of managing our blood pressures. And that's why it's so important to appreciate that the best blood pressure is the blood pressure you take at home. And if the blood pressure at home is not at the level that it should be, then you need to go to the doctor and take more or different antihypertensive in order to get your blood pressure controlled. Because if the blood pressure is not controlled, then the mortality rate is not going to decrease. Any comments or discussions about the fact that the bottom line, is that we're not doing a good job in managing our blood pressures. And so this is something that we can change.
Dr. Callender, I know when we go out to do the health fairs and we take the blood pressure, we do the blood pressure screenings, and we ask them whether or not they're on blood pressure medication. And they'll say, oh, yes, I'm on blood pressure medication, but I don't take it every day, or I haven't taken it this month. And it's just like there's no big concern. And we try to explain to them the importance of you taking your blood pressure medication every day and visiting your doctor before your medication runs out. So people are just very laid back about taking their blood pressure medication.
And this is something we need to change. And I think what you guys do with your screening can help people to understand that they must, just because you take your blood pressure medicine, it does not mean that your blood pressure is controlled. The bottom line is, what is your blood pressure after you've taken your medication? Is the blood pressure after you've taken the medication, when you take it, lower than the 130 over 80 that we recommend? Or if it's still higher than that, then you need to have it modified so that it controls the blood pressure. Because just because you take blood pressure medicine does not mean that your blood pressure is controlled. And I think your point is well taken. Yes.
I have an opinion about the blood pressure. I think it's stress related. I think it's related to politics. I think Donald Trump raised the blood pressure of the nation. I'm serious.
Well, but it really doesn't matter because there's treatment for it. So I don't disagree with you. I just think that in spite of that, there's blood pressure medication that controls the blood pressure, and it should be taken in order to control it. What you've identified is just the stress factors. The stress factors are everywhere. And I couldn't agree with you more about the causation, but we have the treatment. And therefore we should take the treatment seriously and take more of the medication in order to control the blood pressures that are high for whatever reasons they're high for.
Dr. Callender, I was one of those individuals that Joyce was talking about. At first, I was very nonchalant about it. I'll take it when I can and when I feel, when I think I feel. And then I was agreeing with John Buchanan also. I thought it was stress related. So when I was a caretaker for my mother after she passed, I said, well, I don't have that stress anymore, so I don't need to take my blood pressure medicine. Those type of ideas and thought patterns or lead people to detrimental. We should not think about that. What Dr. Callender was saying, if we can get the message out to people, sometimes it's hereditary or etc. But until it proves with the medicine and try not to get off of it and everything, because it is a silent killer, those other things that can contribute to it, I don't think they should be spread around as much because they'll have people like me thinking, well, after I'm through with this stress, I don't need my blood pressure medicine anymore, or I'm feeling okay, or I can take it every other day and still feel the same way. So they're not myths, but they somehow should be combated because like my doctor said, he looked at me in amazement. What? You quit taking it because your mother passed? And, you know, he tried to tell me, and he did tell me that I should continue to take it.
One of the things that, I have a sister who just died from complications of hypertension, and she had a stroke. And hypertension is a common cause of arteriosclerosis. It damages the blood vessels, causes the arteriosclerosis, which then causes clots in the brain and other things. So that it's a silent killer because it doesn't give you any symptoms until you have a stroke. And many of us who are over the age of 65 die from those strokes, some of which are related to the fact that our blood pressure is not controlled all the time. So keeping the blood pressure controlled, regardless of the etiology, whether it's stress or not, it becomes very important. And that's why taking your blood pressure at home becomes the greatest way that you can control your own blood pressure. And that's what is necessary. Any other comments or thoughts? Thank you.
Yes,
Yeah.
I have a question. What are some of the other things that you can do besides taking medicine to control your blood pressure?
Well, lowering your salt intake is one thing. The exercise, 150 minutes a week, and meditation, 150 minutes a week, are the non-medication ways in which you can control your blood pressure. Losing weight is another way. Decreasing sugar intake is another way. So those are some of the ways. The commonest, one of the commonest ways, is, of course, is reduction of salt, sodium salts. But the other exercise and meditation as well. Elizabeth, you had a comment to make?
Yes. Good morning, Dr. Callender. Good morning, everyone. Yes. With the diagnosis of my father, when I first discovered, is when I started studying about high blood pressure, and that was before I was diagnosed. And then I was diagnosed, and I started working vigorously, first trying to help him, and that knowledge helped me. But I too, and one of the key things that you said that really helps me along the way was medication understanding. And because you go to these screening and they say your blood pressure is this, and you look at them like, okay, well, what does that mean? And that was before people started explaining, like you, for us to have a better understanding. So that medication understanding, the things that we discuss, like food understanding, is so helpful, because that the information we're getting today, if we had known that years and years ago, it would have been great helpful. So now we're sharing that with other things. But I've learned how important that medication is. because I have a schedule that I make sure that I try hard to stick to that schedule, because some medication, I believe, Dr. Callender, has a release time, right?
Yes.
You take it in so many hours, it releases, and then you need to take it to make sure that you don't have a gap overlay. I had to learn to understand that, how important that was. The understanding of natural food I had a big awakening. That washing those, one day I was going to the doctor for a blood pressure reading, and I ate a boiled egg, protein, and I ate spinach. And when I got to the doctor, my blood pressure was way up. So my daughter and I started investigating spinach, and we found out if we look on the bag of spinach, it had sodium. And it's a lot of eye openers, but I really thank you for these sessions, because it just enhances me to understand it better and better. And I just want to say thanks.
You're welcome. Any other comments? Because it's such an important topic. Now, this is interesting because intermittent fasting has been associated with improved health. This article says intermittent fasting is linked to higher risk of cardiovascular death. And keep in mind that this is a research study that was done between 2003 and 2018. And they studied some 20,000 adults. And some practiced intermittent fasting. And as a consequence, they concluded that this contributed to their cardiovascular diseases. This is not a study that tells us what percentage of the population was African American, but it does identify that that for some, those people who had intermittent fasting was associated with increased cardiovascular diseases. But whether or not this means that intermittent fasting is unhealthy remains to be seen. But this is what this study did find, that intermittent fasting was associated with higher risk of cardiovascular death. So they're talking about people who are eating fewer than 8 hours a day, and those who ate for 12 to 18 hours had had a higher risk of cardiovascular death. So as far as I'm concerned, this is not enough data for me to believe that intermittent fasting is associated with, but at least this study did. I would need to know what kind of people they're talking about, who was involved in the study, how many people were people of color, and those other things. But anyway, this is still a study that is associated with people who skip meals and all that have an increased risk of heart disease and death. It's food for thought, but I don't think it's enough for me to conclude that intermittent fasting is really unhealthy. Although this is some data that does point to that. I don't know any of you out there who are intermittent fasters, but there's some data that has already said that it was healthy, and now we have data that says that it's associated with increased mortality rates. And one of the things that Dr. McDonald Pinkett mentioned in her talk yesterday is that last week, it's important to understand the studies that you have and what particular portion of people of color are involved in the studies, and also whether or not there's enough data to indicate that the results are consistent. So this this study is suggestive, but we need to see more studies like this and also identify the patient population. Any comments on this article, and those of you who promote intermittent fasting out there?
Dr. Callender, this is Sylvia. Good morning. I was kind of surprised when I saw that article because a lot of people are doing the intermittent fasting and eating only within a certain number of hours, but it was you eat sensibly within these hours and then don't eat for the next 16 hours, give your body a rest. And so many people doing the intermittent fasting is lost weight. They say their health is much better. So I was kind of surprised when I saw this article here. So, I don't know, sometimes we get information said you got to do this, then the next thing don't do this. It's, it's like you said.
That's why I made the comment about you have to take it with a grain of salt, and that's why I would take this with a grain of salt and see what additional articles come out. And also, I wouldn't need them to qualify. Tell me what kind of people who did this.
Yeah, and I think also this intermittent fasting, it's like when you're hungry, eat. You don't have to just eat breakfast. I know Carol Tatum always gets on me when I say I'm not hungry. I don't need breakfast, but when you're hungry, you eat. What about that philosophy, or do you have to?
How many of us really have ever had hunger pains?
Never.
You ever think about that?
We're blessed. We're
Right.
blessed here.
Yeah, most of us haven't been hungry. We have a little pang and we say, "Oh, I'm hungry." Yeah, but is that really hunger pangs, or is that something that we're used to eating, so therefore we eat? That's a question, but I don't know the answer.
Yeah. Sometimes we'll see, we could be watching TV and see a picture about a cookie. We're like, oh, I need a cookie too.
That's not.
So yeah, it's sometimes it's psychological.
Yeah. Any other comments or questions about this article?
My question, Doc, was that there had to be a concern about this many years ago, because this study, it says, was between 2003. I mean, that's, 20 years ago. Somebody thought that there could have been an issue with this. So I was just wondering, what made them consider the possibility that this could be harmful.
Well, I think the possibility that it could be helpful. They thought it could be helpful, so they looked at it and they found out, in point of fact, it wasn't helpful. Although you got to look at this also, that some of this is work done in China, and whether it applies to us or not remains to be seen. And that's why the patient population, I would need to know more about it before I would really think that this applied to us. So that's just a point that when you read articles, you have to always take in consideration, who are they talking about? And if they're talking about Chinese, they're talking Americans, they're talking about people of color, talking about who are they talking about? And there's the research control for the population. And so this is interesting work that suggests that we need to do even more work to find out the answers to the question.
Dr. Callender, my mother used to tell us that we should never eat when we're not hungry.
Well, our mothers and fathers were wise. They usually gave us good advice.
And the other thing, has anybody ever thought about eating only to take away the hunger pains? No other reason, just wait until you're very hungry and then you eat. Otherwise, just don't eat.
That's not American. Good question. I don't know the answer to that either. Well, as this article talks about, 81 million people will be complaining because of the allergy season upon us with the pollens and all of that stuff. Any of you fall in that category? Because this is something that we can minimize by keeping the windows closed, taking showers and having filters in your house and having air purifiers. And that's staying inside. So this food for thought, because many of us fit into this category.
Dr. Callender, I had an observation. So I never had any allergies my whole life until I think I was 53. I think I remember. I was in my classroom and the landscapers were outside, mowing the school lawn over the spring lawn. And, the dust from the cuttings came up and the pollen came in and my eyes started running and I started sneezing. That's when I knew that all of a sudden I became sensitive to the pollen. And ever since then, come the pollen times, I get a little bit, not as much as I think a lot of people who are really allergic, but I never had any before that time. And now, since that time, I've been sensitive to the pollen.
Interesting observation. Anybody else have similar observations? It's just like people who suddenly, when they come home to me, become allergic to shrimp or other things, and I don't understand it either. And, it's food for thought, and maybe we can get an allergist, immunologist to help us understand that.
Dr. Atto knows something about that.
Dr. Callender,
Yes.
we're talking about allergies. I have asthma and sarcoidosis, and I don't cough as much. I'm on an inhaler every day. And recently, I've been coughing. As a matter of fact, I had a coughing spell a while ago. I had to get up and get some water. And is it due to my weakened lung system? That it is allergies. I mean, it's pollen in the air. It's stuff in the air now that we didn't have a month ago. And even though I have an inhaler, my respiratory system, I feel it. Is asthma a form of allergy?
Absolutely. One of the most common forms of allergy is asthma. Yeah, it's an atopic reaction, but asthma is one of the commonest forms of allergy.
Mm-hmm.
Yeah.
And recently, spring coming and the buds, and everyone's getting excited about the cherry blossoms. I feel it. I feel it in my voice.
Yeah.
And it too shall pass. But right now, it does affect me. Mm.
Yeah, I think we mentioned before that inside air quality is worse than outside air quality.
Yes.
And so, things like changing your furnace filter or wearing a mask when you're indoors could be helpful.
Okay. Yeah.
Dr. Callender,
Yes.
I developed an allergy to shrimp when the summer that I turned 40. I had never had any allergies for any kind of seafood. I used to eat crabs, shrimp all the time. And I ate a piece of shrimp and I had anaphylactic shock.
Wow.
And I had to drive myself to the hospital.
Wow.
And when I got there, my hands were swollen, so swollen I couldn't talk, but I put my hand to my throat and they knew exactly, and my eyes were swollen, and they gave me the injections. And now I have to, since then, I've had to carry an EpiPen with me, just in case, because I've gotten stung by a bee. That also will send me into anaphylactic shock. But that was all of a sudden. I'd never had any allergies before that.
That's an interesting phenomenon that I've become associated with a number of people who've had the same kind of response you had. And any other comments or?
You know,
Dr. Callender, one thought I remembered was that on those nice breezy days, my grandmother and my mother will open all the windows in the house. And I was a child that always had a question. And I says, why are you opening all the windows out? She said, to let the sickness out and to let the cool breeze in and to clean everything in the house. And it did. I mean, she would open the window so it was a balance. One window, the air would come in and the air would come through the house and go through the other side. So that was very interesting.
Yeah, yeah. Okay.
I was gonna add, Dr. Callender, with this weather that we're having here in DC right now, extremely dry, and all the flowers coming out, the pollen. This is the time of year when a lot of those allergic reactions come up.
Absolutely. Pearl, did you have something you wanted to say?
No.
Oh, okay. All right, let's go to the next one then. No one comes. It's an interesting article because it also is adding to the fact that syphilis is markedly increased. 17.3% increase. And one of the articles suggests that syphilis is relatively rare now, and so many times doctors aren't able to even make the diagnosis. And so they suggest that if doctors see skin reactions or other reactions that are unusual, they get syphilis tests, because syphilis is a disease that has many faces and it presents in many forms, and skin manifestations, genitalia manifestations, and neurological manifestations. So when you find something that doesn't fit, make sure it's not syphilis, because it's of course a sexually transmitted disease, probably one of the commoner sexually transmitted diseases. But we're having so many cases now. It is one of the tests that you must always do if you have a patient who has any kind of neurologic or eye or other symptoms, even ear symptoms, deafness. And they are suggesting that the healthcare providers, because they're not used to making this diagnosis, that they get tests for syphilis in people who are sexually active. So this is something that we haven't had for a long time. I mean, we had syphilis, but haven't had a kind of an epidemic of syphilis like we're having now. Any comments?
Yeah, Dr. Pounder, we talked in previous sessions. One of the reasons why there was an increase in syphilis, and that's because the senior citizens and nursing homes are living longer.
That's because they're living longer. Now, is that what you really mean, or you're not? You mean they're sexually active longer? Is that what you mean?
Yeah, both. Yeah.
Yeah, because okay. Well, that too, but this involves the younger and the older population. But you're right. The senior population is sexually active as well, and as a consequence, the importance of getting tests for syphilis in the young and the old becomes important. We're used to, in the days when syphilis was more common, we used to recognize that it was a disease that had many faces. And just about every organ system you can imagine has been affected by syphilis. And so just getting a syphilis test is easy to do. And so a diagnosis of infection or reinfection can be made, and it can be treated successfully. So,
Quick question, Doc. What is otic syphilis?
air means you have ear, and it causes deafness as well.
Wow.
So the ear and the eye. Ocular is the eye, otic is the ear. And then the brain, of course, is neurosyphilis.
And I think it's important to talk about sexual activity. You said sexually active. What do you mean by active?
Well, and I think Darryl mentioned this last week or the week before, that the activity with more anorectal sex and many other interests in pornographies result in people having more sexual active, whether it's anorectal sex, vaginal or oral. Wherever you have these lesions and you're sexually active, the syphilis bacteria can affect the mucocutaneous membranes of the mouth, the vagina, and the anorectal area. So if you have sex in any of these areas, then with people, with other people in any of those areas, then you have the possibility of getting syphilis. Lucy, did you want to be any more definitive than that?
No, it was more of, what's active to somebody who, the difference of having sex once or twice a month versus someone who has it weekly or daily.
It doesn't matter whether it's once
No,
a day or once a week or once a month.
right. So your concept would include a larger number of people. So especially with what you gauge as being active. So if someone who was having sex more frequently and has over the last decade reduced those encounters, it's a small point, but it's important for history. So any sexual activity versus sexually active. I know for teenagers, when I made the distinction between having any sex versus being sexually active, it was a distinction. So those who weren't having it all of the time didn't think that they were sexually active, if they weren't having it daily. So they said, no, I'm not sexually active. Or activity was associated with multiple sex partners.
Yeah. Well, thank you. Any other comments? As our children and grandchildren and as John Tatum mentioned, and the seniors as well are having sexual activity, and
I would like to thank her on that last comment, because you should just say if you're having sex, because even when girls get pregnant and they said I've only had it one time, you can get pregnant just having once, or if you're doing it every day. When they put that word active on that behind sex, that just makes you think, oh, I got to be an every day or 2 or 3 times. And that active really messes people up.
Well, thanks for clarifying. Okay, good. This is an interesting article that talks about how to communicate updated colonoscopy intervals to patients, because there's a lot of changing now from 5 years to 7 to 10 years. And the question is, how do you do it? By telephone, secure messaging, or mail? And they looked at all of the different ways to do it. But the change, though, is that they're moving it actually from 0 to 5 years to 7.5 to 10 years for patients who have a low risk. And if you've had a polyp, then it's still frequent 5 years. But if you have not had a polyp, they talk about 7.5 to 10 years. And so they're trying to think of the best way to communicate the change in the interval. And so they looked at the different ways, and they decided that the three-arm way was the best way. But I think one of the things that is important to recognize is that the cost-benefit ratio of colonoscopy, and what age should you have it and which age should you not have it. And I think most people would say that if you don't have a history of cancer in the family, especially colorectal cancer in the family, then the ages of up to 80, this article says 70, but some people say 80, and they also say that it all depends upon the nature of the person. If somebody's 70 years old and in good health, they think that they probably could have a colonoscopy. If they're over 80 and in poor health, then the odds of whether or not they need a colonoscopy may vary, especially if their previous colonoscopy was without polyps. If you've had polyps, then there's little question that you should have a repeat colonoscopy within 5 years. The question is, how did you communicate that? And I think the best way to communicate that is in person, although mail letters and telephone calls work well also. But I think it's important because the patient should be notified formally as to when they should come back to have another colonoscopy. And also should understand that if the colonoscopy is incomplete, that means they have not had a colonoscopy. And I think this is something that is important. And then they have alternatives to colonoscopy. They barometers, and they have colonoscopy, and they have a system where they can actually give you barium, and you swallow the barium, and then they can follow it all the way out throughout the colon. So for people who can't take the conventional form, or haven't had the conventional form, there are other alternatives. But colonoscopy is an effort to prevent adenomas or tubular adenomas from developing into cancer. So it's an answer to prevention. And if you find an adenoma in the colonoscopy, you take it out. Then if you find a cancer, then you need to have surgery to remove it, whether it's by the colonoscopy or by a separate surgical procedure. Any comments about colonoscopy and when to have colonoscopy or when not to have colonoscopy? No comment about the colonoscopy? One of the things about colonoscopy was the prep. Sometimes the prep is so exhaustive that some people prefer not to have the colonoscopy because of the prep, but that is being done better.
Dr. Callender,
Yes.
the frequency of colonoscopies, I think, is 10 years. Then they say if you find a polyp, it's 5 years.
Right.
And if you found a polyp and more than 5 years later, it hasn't been detected, do you always stay on the 5-year regimen or do you ever go back to the 10 years?
Yeah, if you have a colonoscopy and they find no polyps, then they may go to the 7.5 to 10 years. Mm-hmm. But if you have a polyp, it's usually 5 years or less, depending upon how many polyps you have.
Mm-hmm.
And for some people, it's annual. Yes.
My father developed colon cancer at age 88 and was successfully treated. So my brothers and I would have colonoscopies every 2 years for about 3 years. And the last time that we had one, we didn't have, none of us had polyps. So they told us we could go for 5 years now, and that we should just continue to go 5 years because of our father.
Good. Sounds good advice. Yeah, sounds like very good advice. Okay. Okay, any other comments about that? If not, we'll go on to this article that identifies neurological conditions in 43% of the world's entire population. And as we age, we get more neurological issues. Then, of course, stroke, brain injury, Alzheimer's, and dementias, all of those fit into the spectrum of neurologic diseases. It's interesting, as you age, every year you make, you find something else that people have, and sometimes we don't appreciate how blessed we are when we don't have any of the neurological diseases. The commonest of all of them does appear to be the stroke and the Alzheimer's disease. So what is the bottom line when you have such a? I think the bottom line is that getting your annual physical and finding out if there are any changes that require you to have additional tests to search for neurological or other diseases as you age. Which brings us to the subject of the gerontologist, because as you age, when you're over 65, the doctor that probably is the most important for you is a gerontologist. But there are so few gerontologists that to keep up with the ever increasing senior population, the gerontologist makes up only 1% of all physicians. But that's the doctor that is best for somebody who's 65 and older. Any comment about this observation of, we talked about cardiovascular disease. We haven't talked about the neurological diseases other than dementia and stroke. Okay, I guess this will be the last article that, I don't know how many of you remember the Havana syndrome, but in Cuba, the diplomats complained of mysterious health problems, especially inability to think and balance problems, headaches, and other things. And so since that time, they've studied the brain and tried to find out what caused this so-called Havana syndrome. And so far, they've found that there are no brain injuries associated with it. That doesn't mean that they didn't have something that disturbed the neurological system. It just means that we couldn't find it. And that there's no intrinsic brain problem. And so it remains a mystery. I just put it there because many of you have heard about the Havana syndrome and wondered what had happened. And the bottom line is we have no clue as to what caused it. We just know that people behave differently, and we still don't know why. Okay, I guess this will be the last article, and I guess we can, comments on that, we can just conclude with that one. We've had our largest audience today, and thank you so much for attending and for asking all the questions that you did and giving us some of the answers. Any closing comments?
Dr. Callender, going back to the colonoscopy one more time, we didn't talk about if you did find a polyp, that you do a biopsy of the polyp to see if it was
you take it
benign.
out.
You took it out, but you do a biopsy after you take it out, and to determine whether it's malignant or benign.
That's correct. Yes. And if you've totally removed it, it's benign, no other treatment is necessary. If it's totally removed and the biopsy shows that it is confined to the polyp, there may be no additional treatment necessary. Or if you can't remove it and the biopsy shows it's cancer, then you need to have additional surgery.
Carol, you were muted.
Oh, there was one time we talked about our immune system, and we're talking about a little dirt. And the reason that this generation has more problems with immune because we're a little bit too clean because we washed everything when we didn't. But I know more chemicals are being added before. But like peanut allergies, our children have more allergies than they ever had before. And I was wondering, there's different countries where they're not that clean, once a child is born, and their immune system seems to be stronger than our Americans when we're in such a sterile, clean environment. Any thoughts about that?
Not really. I know you're right. We talked about that many times. And nowadays they're getting drugs that treat all kinds of allergies, even the peanut allergy. But I don't have any thoughts about it. I do remember those conversations, and I remember John Robinson was one of the ones who felt that we were too clean, and that as a consequence, our immune systems weren't as active as they could have been. So
Yeah, because we used to drink from the water hose, and we played in dirt, we might eat dirt, but it just seems like the children nowadays are so sterile, even our infants when they're born. I know we're doing this to prevent the diseases, but I'm just thinking about, I hate to use the terminology of third world cultures, but are their children surviving better than our children in this clean environment?
well, you have to understand that the mortality rate in different countries varies so much. Some countries, the mortality rate is at 40. People die at 40. Some people die at 30. And so it varies. You have different third world cultures that have different mortality rates. Lucy, you have any thoughts about that comment? Dr. Perez, you still with us?
Yes, I am. And I know when we talk about mortality and the article that you said in terms of infant mortality and infant and maternal mortality, despite all of that, we don't have answers to it. We, in this clean environment and access that other populations don't have, we are doing worse. So there's so many different aspects that impact that. So in terms of having an environment that is cleaner, quote unquote, and its impact on children and mortality, when we correct for those communicable diseases for which we have antibiotic treatment for, there's no comparison.
I mean, we're worse
So
than other countries.
I really don't have a comment. I know when I was in practice and associated with children of varying ages for a good 30 years, I never had a cold. And I believe that was because of the micro infections that I had because of the children that impacted me.
Yeah.
So
Well, that's
it's
yeah, yeah.
Go ahead. No.
I was going to say it's very interesting to get an answer to the interesting comment that Carol made that we made many years ago to see if that still stands because the theory is that the more you're exposed to antigens, the more likely you are to develop immunity to them. That was the prevailing concept.
Well,
and I guess
in thinking,
now that so many people are wearing masks, whenever they're in large populations and things like that, because of COVID, with that principle, we should have then seen a increase in infections now because we haven't had those micro exposures, or are less likely to have them.
Darryl, you had a comment?
Yeah, I don't really think we live in a clean environment. Our air quality in the United States isn't that good. We've got a lot of problems with water quality, with lead pipes. We've got more processed foods in this country than the rest of the world that leads to the prevalence of bad gut bacteria. And so we're in a very much toxic environment, regardless of how clean we think we are. Um, like when you look at blue zones, the people that have the longest longevity are ones that live in non-urban areas, more rural areas, eating natural food. Civilization isn't doing. We're highly civilized, highly processed. Lots of nanoplastics that are invading everything. Um, like living life in a simpler blue zone is, I think, a whole lot more healthful and therapeutic than our typical American environment.
The thing that is most alarming to me is that we spend more money on health than any other country, and yet we're about 20th in the world in terms of health. And so, but yet, you look at some countries where the native, the infant mortality and maternal mortality rates are so much better than ours. But then you still have countries that are worse. But I think that the infant mortality and the maternal mortality rates, there's a question as to why we are so low in terms of having such high maternal and infant mortality rates. So I don't know the answer to your question, Carol, but I do know that our our infant mortality and maternal mortality rates are much higher than any other country, any other developed country, because the undeveloped countries, they have lower rates. But I think that one of the most recent ones, we were about 23, which was pretty bad. So I don't have a good answer to your question. It's a good question. I don't have a good answer for it.
Well, I guess during this spring break, when the children in PG County there and Howard County, they're out. So I won't encourage them to make mud pies. But I thought